excited. Dr. Miranda, can you tell us a little bit about you?
I am a professor at Texas A&M University. I teach medical students part of my time. The other part of my time, I run a research laboratory. We do work in both animal models of fetal brain development, early fetal development, and the intersection between drug exposures and fetal development. And then we also work in different human populations in the arena of pregnancy and predicting birth outcomes and such.
Fantastic. And I know Leah is just in charge of so much of collecting the data and working on it and being part of the co-chairing of the Texas Collaborative of Fetal Alcohol Spectrum Disorders. So tell us a little bit about how did you get into that?
Hi, I'm Leah, and I'm really always excited and honored to get an opportunity to talk with people that we don't normally talk with about FASD. So thank you both for having us. I've had the privilege to work with Dr. Miranda and Linda Kagi, who you guys I think know, for many years around fetal alcohol spectrum disorders. I got into this work by way of being interested in people who have to live with multiple levels of life circumstances that are adverse or difficult or challenging. And that led me to working with people interested in the area of working with persons who have intellectual or developmental disabilities. And that kind of led into learning more about substance use disorders and FASD. And so I've been working in FASD for about 10 or 12 years now.
I'm glad you guys are, and I'm glad we had this opportunity, explanation of what it is for our listeners.
Sure. At the very basic level, fetal alcohol spectrum disorders is a series of physical signs as well as behavioral and brain deficits, problems, anomalies that are associated with exposure to alcohol during pregnancy. And these signs can range from what we know of traditionally as part of the FASD continuum, which is mid-face anomalies, growth deficits, decreased head size, problems with behavior like attention deficit type disorders, memory, ability to work with numbers, to very subtle deficits. And sometimes these deficits don't go together, and which leads to the issue that you mentioned. Mid-face anomalies that we associate with fetal alcohol syndrome actually occur in a very, very tiny fraction of the cases of individuals who might be affected by prenatal exposure to alcohol. A vast majority of these individuals who might have equally severe behavioral problems or behavioral anomalies may never show the mid-face deficits like a flattened filtrum, thin upper lip, epicanthal folds, and so on and so forth.
So if a child is born with a fetal alcohol spectrum disorder, unfortunately in our state, but beyond that, there aren't many docs doing FASD diagnostic assessments. So most people who do have an FASD grow up never having a diagnostic label that matches with an FASD. What happens often for many?
It's crazy. You keep going in a second, but that is crazy if it's a disease that occurs 1 out of 20 people may be affected.
Right, exactly. I'm with you. It's wild. And that's a whole nother, how do we get docs to look at this? But that lends itself to the point I wanted to make, which is that there is a bunch of bias and judgment in the way that women get asked about their use. As you guys know, whether or not you're pregnant, or the way people are asked about their use. And so if a doctor says to a woman, perhaps as an example, in a leading way, you're not drinking anything, right? While she's pregnant, the kind of safe answer would be no, not much. I mean, right. Not me. I mean, So we have to train people, medical professionals, to ask these questions in a different way that is non-judgmental and that is supportive. And part of the trick there is that if you have an FASD, you need confirmed maternal exposure to get a diagnosis. So what happens in lieu of confirmed maternal exposure, for whatever reason, mom doesn't get asked properly, or she doesn't want to acknowledge it, or some combination of factors. What ends up happening is that people who have FASD typically get a whole bunch of other labels in their lifetime. Lots of times they acquire labels that might not even be really appropriate diagnoses, like personality disorder labels, like ADHD, like conduct disorder, those kinds of kind of judgy, some of them labels get stacked on to people who might really have brain-based differences caused by alcohol.
Tell us about what's hopeful out there in terms of interventions? Like what support is available? Like what programs, what can we do once it's identified? And I want you to talk about children, which probably you know a lot, and maybe speak to adults, somebody that would show up in our facility. Like what can Julie and I do? And this is past the development when they've been misdiagnosed, they're in the system, probably institutionalized. What can we do? How can we adjust our treatment or behavior to help outcomes, help their health?
Well, luckily, there's some relatively straightforward things we can do to help. And one is understanding that people might not be where we assume they are based on their age, their chronological age. We have to always think about kind of stage, not age. So where is a person in their thinking level about life circumstances? So maybe they're entering your work, Julie and Dr. Powers in the treatment world, and they're kind of like, okay, here I am, like I got sent here, or I'm here now because I want to make a change. Whichever reason they're entering the door, the question becomes, how can we better support them? And I like the idea generally of thinking, what do you actually need, and really listening to that, hearing that, and also observing how can I best support the person. Some simple strategies are persons with an FASD, remember we mentioned earlier, aren't necessarily great at abstract thinking. So one of the strategies that we know works well is providing information in multiple formats. So instead of just what happens often when a person enters a treatment setting, they get like a huge rule book, right? And they're told, follow these rules, do what you're supposed to do, and see it through, you'll be better on the other side. Like, okay, that's a really abstract concept when I've just been through this hard part of, or I'm in this hard part of life. So instead of saying, here's the rule book, we can say, here's the rule book, and let's talk through this together. What does this look like? What does this mean to you? How will you do this? And then providing visual reminders in a non-judgmental, non-punitive way. That's just a single example. But basically, breaking things down into smaller chunks is a really helpful approach. Using methods like role play is a really helpful approach of practicing a social scenario, for example, that might otherwise be a trigger for a person who's in recovery. We might want to act those situations out rather than just telling people you need new friends, don't hang out with the same people, do better. Like this kind of patronizing messaging isn't good enough and isn't helpful.
One of the things we're learning is that fetal alcohol is actually a whole body disease, and it's not just the brain. And there's a cardiovascular component, there's endocrine components, there is metabolic components. And it is possible that if you pay attention to the surround around the brain, the person's cardiovascular health, endocrine health. Actually, one adult with FASD told me once that maybe if you take care of my hypothyroidism, I might not be intellectually disabled as all that. So if you, as a physician, look at the whole person, there may be things that you can do once you discover that they may be hypertensive, for example. It's surprising how many even teenagers with FASD are hypertensive. So if you look at that, maybe if you control hypertension, other things might work themselves out. So maybe the hope is if you can look at the whole person rather than their brain function.
Thank you. I needed that reminder. Thank you. That's well said. And Leah, what you said was great too. And I just got to brag on Julie, and it reminds me of an email that she sent out to everybody that works for us. And it was exactly that advice. Like, okay, guys, slow down. Let's figure out where the person's coming from. Let's just pause. And they're not being defiant, but maybe it's an understanding issue.